Ladies and gentlemen, welcome back to the Thorax Center for another live IVUS course. My name is Joost, Daemen, interventional cardiologist here in the Thorax Center in the Erasmus University in Rotterdam. And I'm doing this course, as always, with my partner in crime, Jurgen Ligthart, who is one of our senior imaging technicians. This course, again, is sponsored by ACIST Medical, and our aim is to guide you through some of the basic concepts and principles of invasive coronary imaging using intravascular ultrasound, plus provide you with each time some specific cases and tips and tricks to learn to appreciate the different types of coronary or intracoronary pathology, and things you might encounter to further tailor and guide your PCI in the routine clinical practice. So if we can go to the slide set, next. Okay. Yeah. So the concept of today again is that we will make this course interactive. So your feedback is highly appreciated. There, please use the chat function within the Zoom window to connect with us, and we will try to address all of your questions. So the concept of this course is to provide you with a step-by-step IVUS guide to learn you how to use IVUS in your routine clinical practice with the use of the ACIST HDI IVUS system and the Kodama catheter. We will focus on some basic principles, recognize different types of plaques, procedural planning, and learn you how to guide post-procedural oriented in a course, again, that is very practically oriented. So for those of you who are new to the course or are dialing in for the first time, we always start with a very, very short key basic principle concepts that Jurgen will address.
Okay, thank you, Joost. Well, our first slide here, we see the ACIST system, and immediately you see a normal coronary artery, a cross-section of a normal coronary artery. And as you know, our vessels, our arteries have an intima, media, and adventitia, and that is exactly what we see in this high-frequency catheter, that we have the three-layer appearance. So we see the intima, we see the dark line in the middle of the media, and then we have a strong reflection of the adventitia. At the adventitia, we see the leading edge with the back of the adventitia falls away in the background. And yeah. Here again, we see now we concentrate a little bit for why we see what we see. Here again, we have the normal artery. Now the intima is, you can recognize as a dense layer, will appear as a gray layer, and as a gray layer that is only for a normal intima. And we will see in the coming few slides that normal is looks a bit different than abnormal looks a bit different. The media is made of smooth muscle cells, and that is for ultrasound, is it homogeneous. So there will be no differences in acoustic impedance in there, and that means there's no reflection, and that's why the media appears dark. And the adventitia, that's collagen, and that collagen is has a high difference in acoustic impedance according to the surroundings, so you have a strong reflection of that. And as said, the back of the adventitia, because this layer, of course, is also quite thin, the back you cannot appreciate because that falls away in the surroundings. Yeah. Well, here we see actually 95% of the plaques that you can appreciate in a diseased vessel. And if we go from left to right, then we have fibrofatty, in the middle fibrous and calcified. Actually, I always say this is lesson 1 for interpretation. What you do that is, you look at the cross section, you see the media, and you look then at the outside of the vessel, and that you take as your reference density. So all the plaque that is darker than the reference density, you can consider as fibrofatty. It's a bit roughly said. If we go to the middle, all the plaque that is just as dense as your surroundings, but where there is no shadow, you can classify as fibers, is more stiff. And then you see that we go from left to right, that we get harder plaque. At the right side, we see calcified plaque. And what you see with the calcium, that we have an acoustic shadow behind there. And that is because calcium has a very high acoustic impedance and therefore a very high difference with the surroundings. So everything will be reflected, and what goes through will find this wall of calcium on its way back. So behind the calcium, we will not see any information. So the picture stays dark. That's different than the homogeneity of the media, because they can look through the black appearance. Yeah. Well, to get all these nice things, you need an IVUS catheter, and one of the first basic principles is that you do a proper preparation of your catheter. Your new catheter there's an outside sheet. In the outside sheet, there is an ultrasound probe rotating. And what you need to do is to flush the catheter so that there is a film of fluid between the ultrasound probe and the outside of the catheter. If there is air in there, then air that is for, then you see, like in this movie, then you see that the picture gets darker. And I can tell you, it always gets dark on the wrong moment, just at the spot what you want to be interested in. And for your convenience, we made a small movie in the way how we in the lab prepare the catheter. So first we connect the syringes. We prefer to put the big syringe, the 12 cc syringe, on the side, and the small syringe on the left. The 12 cc syringe we only use as a sort of petrol tank, but first what we do with the big syringe is to flush once in the way how it is in the package. Then we pull the probe back until the stop, and then we start working with the small syringe and we flush again. And then a very important movement is that we go strongly halfway, and that is to release the small air bubbles that are attached to the spring, to the coil that is driving the ultrasound probe. Then we're ready to connect, and after connection, we flush once again while we check the image, and then you need to see, a circle, a bright circle with reverberations. And you test the catheter always in the air outside the patient. If that's the case, then you're happy. And in 95% of all the cases, you can make beautiful boulevarks without reflushing.
Okay.
Yeah.
Guidance engagement, second important step of the image preparation process is that you always make sure you use the full pullback length of the catheter. In this case, the lesion is rather distally, but we always recommend to pull out the guiding catheter of the ostium in order to allow a full appreciation of the full length of the pullback, not just of the particular part of interest, which here, for instance, in the distal posterolateral branch, but specifically with this system, which allows you to do faster pullbacks. We'll get to that in a second. Please make use of this and use and image the full vessel, including the ostium, which in some cases might lead to very interesting information, as we will share with you in several cases we have prepared for you today. Okay, let's continue here. So as mentioned, so the key, one of the key principles of this course is to learn you how to recognize different types of plaques. But with today, we have a special issue based on the request of several of our attendees. We created a specific session today focused a little bit on hematomas and aneurysms, since these are things in which we believe, as of course heavily biased intravascular imaging users, that the use of intravascular imaging will really change the way you treat your patient and will definitely lead to a more academic and perhaps also better a treatment algorithm in these specific cases. So as you know, hematoma is a concept. Hematoma means bleeding in the vessel wall, but the point is that the hematoma might have several distinct causes that might warrant completely different treatment. And for that, we created a mixed bag of different cases of hematoma just for you to demonstrate how that looks in clinical practice and how that is visualized or can be visualized by intravascular ultrasound. So we start with a conventional hematoma. So these are the hematomas that you might encounter typically on angiography, not particularly clear on angiography typically, but you at least can anticipate that there is a hematoma. And if you do imaging, you might see them on a routine basis if you would do imaging and put your stent based on angio guidance. So this is a case of a 82-year-old gentleman who presented with unstable angina and a long lesion in the mid-LAD. You can see a very tight lesion proximally or just after the first diagonal branch, with some disease extending also more distally. In this case, we continued with some pre-dilatation and the implantation of a long Trio 35mm drug-eluting stent. We continued here angiographically, T3 flow, nice result, but here you already can appreciate that distal to the stent there is some step down. You don't see a clear dissection, there's no clear thrombus, but these cases, we learned from intravascular imaging, you really need to be cautious and anticipate the fact that there might be some form of hematoma here. But in this case, we did an IVUS post-PCI, and if we could play the loop, Jurgen will take you through the imaging.
We start in the normal vessel, and then put your attention here at 3 o'clock. Then you see, and there you have the stent already. We will repeat it. These are GIF animation because the quality was a bit better. The stent was well opposed, but we're going to concentrate once more on distal to the stent. So we repeat it. Yeah, repeat once more.
Yeah, so importantly, always start a pullback in a distal healthy segment.
And then, and what we saw, and that we made one slide of, here it is. So it's normal. This is a normal vessel. And then at 3 o'clock, you see a mass of spontaneous contrast, blood, what is trapped between two layers of the vessel. And what happened here is that, as you appreciated, that the stent was placed without that an IVUS or imaging was done. So also without the sizing. And what happened is that after pre-dilatation, you create a dissection, what is good because you have to prepare your lesion. But then the stent was placed, it closed the opening of the dissection, but it didn't cover the hematoma there. So the hematoma was starting to walk away from you. And this is the situation. This is situation after pre-dilatation. You can see in red is the blood, and you see this dissection flap, and we have an anterograde dissection that is, and then after the implantation of the stent, then you see that the stent, the edge of the stent, covers the opening of the dissection. So the opening is so the opening is gone. But then it presses the hematoma towards the space of the least resistance, and that is to distal. And if can't go further, then it will start compromising the lumen, and then you get a new stenosis in there, what you want to treat. And these are the pictures that I mentioned. You see in the picture at from 12 till 1. You see non-moving blood trapped behind the medial layer. So it's between the media and the adventitia. The blood can't go anywhere, so you get spontaneous contrast in there, so as non-moving blood. And this is the edge of the stent, and probably it's not that clear. It closes here at the edge, the opening of the dissection. Well, you could have avoided this because we have a sort of 4-step PCI guidance. First you go to see what are we dealing with. And if you have to prepare your lesion, then you check again with the IVUS. And that means also after pre-dilatation, because then you can appreciate the extent of an eventual hematoma, so you can adjust your stent length and the placement of that, and then you avoid this kind of situation. If you're not careful, it's possible that even by placing new stents, that you move the hematoma further distal until there is a point of no return.
Yep. All right.
Yeah.
So in this case, the operator implanted a additional stent with a proper angiographic result. But again, you see some little bit of tapering distally. So what typically happens with these hematoma is that you squeeze out the hematoma as a sort of a sausage.
Yeah.
So placing additional stents, there's no black and white guideline on when or how to do that. But the I would say the key recommendation is look at the residual minimal luminal area, which you have at the side of the hematoma, which in this case was not that small. And if it's not luminal compromising, then I would be in general relatively reluctant to putting additional stents. Okay, so that was a hematoma. That's perhaps one of the most conventional types of hematomas we encounter in our routine practice. But we've collected more cases for you. And sometimes cases are very unconventional, like this case. So this is a case of a 64-year-old female with diabetes and a hypertrophic cardiomyopathy with severe mitral regurgitation, preserved LV function, and atrial fibrillation, who was referred to our surgical colleagues for a mitral valve repair and a left atrial clipping because of her atrial fibrillation. This surgery was, however, complicated by ventricular fibrillation and a quick deterioration of the LV function, which led to immediate removal of the LAA clip and a anastomosis of a Lima LAD bypass and aorta circumflex bypass due to a suspected occlusion of the left main circumflex bifurcation due to the left atrial clip. And for that, the patient was referred to us for diagnostic catheterization and IVUS to indeed confirm whether this was indeed the case. So you would say, well, that would be a very rare complication. Yes, it's true. It is indeed very rare, but anatomically, the LAA is just on top of the proximal LAD and bifurcation to the circumflex. So anatomically, you could anticipate that this might happen in a very small number of cases. Anyway, this patient was brought to our lab and was filmed. We started with the Lima that was nicely patent. We apologize for the short loop of on the left side, and the RCA was slightly atherosclerotic, but at least nicely patent. But then, if we continue, we can first see already that the venous graft was patent on the obtuse marginal branch, but landed in an area which there was still a small active bleeding. Which was already recognized surgically because this patient already came in with a pericardial drain. And then the key reason for doing this angio was obviously this osteo mid-distal left main disease with the hazy aspect. We knew that would have been trauma from the outside, but we obviously didn't know how this vast vessel would look from the inside and would therefore justify any further treatment, despite the fact obviously that this patient already had bypasses. But in this case, we continued with a intracoronary assessment with IVUS to check how this vessel was tortured from the outside and what the respective consequences were to the inside. So Jurgen, if you take us through the IVUS.
Well, you see that the vessel itself has some disease, but not too much in the beginning. We have here some calcified plaque, but then more proximal, we start to have that we see outside the vessel, and I will point you out where it is on the, we look at the left side there. Then here you see on the top at 12 o'clock, you see the hematoma outside the vessel. That's from the LED. Also here you see immediately the hematoma near, and it even continues to the sideburns to this ventricular branch and goes over in the left main where we are now. And if we look at the right side, there we have the IVUS from the circumflex, and there we see the hematoma, the slow moving blood in the hematoma behind the media. And you see that it is compressing. It tends to compress also the lumen. Here we start to see the hematoma. It's on top on 12 o'clock. You see it's compressing the media inside. Here we have compression on 12 o'clock. We look at the right movie in there. And the strom, yeah, it all can all be thrombogenous. That it's because it's non-moving blood. At the end, everything will be thrombotic. You see even some movement in there. But you see also that the lumen is compromised by this hematoma because it can't go further outside. Yeah, and that.
What is interesting, Jurgen, what I think is interesting about this case is typically with small dissections, you see intimal tears and you see the blood going between the intima and the media. But what is in this case very apparent, and that's why we thought it would be a nice illustration for how you can see hematomas, is that in this case, the vascular integrity in this relatively healthy vessel is actually completely intact, except for the fact that just between the media and the adventitia, you can see that here nicely in the circumflex pullback, this vessel is nicely intact. The only thing, it is being compressed from the outside by hematoma that is, exactly as Jurgen mentioned, submedial, as we call it. So in between the media and the adventitia.
You can recognize that because this submedial space is blowing up like a balloon.
Yeah.
See, because there is some elasticity, but there is less power to counter pressure. At the moment that you close if such happens with by accident in one of your procedures, you can see that the same thing. The moment that you close the opening, then you see that the adventitia is coming back. And that's why it's also very important that if you would place a stent in here, that you never size on the outside of your adventitia, because that's not realistic. And then
Joost, we have a question from...
Yes, we have a question. Would you consider using cutting balloon at distal edge of hematoma to release? Yeah, that's a very, very relevant question and a potentially very practical solution to this problem. The use of cutting and scoring balloons has been reported in patients with dissections. But again, at the end, we don't put stents or any other material to treat hematomas. The reason is to treat narrowings due to atherosclerotic disease. In case of hematomas, you could, of course, attempt to dislodge the blood from the subintimal space by using cutting balloons, which means that you damage also the endothelium and might increase the vulnerability of the patient to additional amount of thrombus and thereby acute occlusions. Conversely, if you have a hematoma that is severely luminal compromising and the patient has active ischemia, you need to do something. And there, I think there is always a balance between, depending on the type of dissection, either putting a very short stent to just cover the osteal tear causing the hematoma, or using a cutting or scoring balloon to dislodge the blood in order to restore the flow. Because at the end, the best antithrombotic tool will be flow by itself in combination with antiplatelet and antithrombotic agents. So yeah, in brief, it's definitely a option that you might want to consider in cases where there is a luminal compromising hematoma. This patient, however, was, as you would expect, managed conservatively because of the fact that there were already grafts implanted due to the quick hemodynamic deterioration periprocedurally. And this patient actually did well post-procedure and went to a referring hospital after 2 weeks. Then we have another interesting case in which we potentially combined two different types of hematomas or intravascular damage, which is either SCOT, so the spontaneous coronary artery dissection, or in iatrogenic dissection, which also might occur following the manipulation of guiding catheters or diagnostic catheters in general. So we want to present you the case of a 60-year-old female patient with hypertension, dyslipidemia, and a family history of cardiovascular disease. She had an osteosarcoma for which she received radiotherapy, otherwise no apparent vascular disease, and she presented with a out-of-hospital cardiac arrest. Was shortly resuscitated, and when she arrived here, she was actually already completely hemodynamically and respiratory stable. She quickly recovered following the resuscitation at home by her partner, was completely in a completely neurological maximal neurological state, meaning that she was at that time completely stable. But she was referred for a coronary angiogram because of the fact that we wanted to check, obviously, for coronary causes of her out-of-hospital cardiac arrest. Well, this was her EKG at the time of presentation, showing you atrial fibrillation with a heart rate of 135 beats per minute, with diffuse ST segment deviations and some slight ST elevation in AVR, suggesting potential left main or tree vessel disease in this patient with a increased risk of cardiovascular disease and a female gender, which of course could be a predisposing factor for SCOT. This was then her coronary angiogram, showing you already the first abnormality being a normal right coronary artery with a aberrant left circumflex arising from the right coronary cusp. And then you can see a LAD. And what you could see, or at least what we appreciated in the LAD, was actually at first very mild disease. A left mainlet looked fine, and the LAD, however, that showed after the takeoff of the so very long left main, and after the takeoff of the circumflex, a very mild stenosis here in the LAD, which we could not really appreciate, but what you could also appreciate, and I think this is very apparent, is this diagnostic Jurgen's left 3.5 catheter, which is pointing very aggressively in the roof of this osteo LAD. This patient was hemodynamically stable at the time, so we proceeded, exchanged for a guiding catheter, actually without any problems, re-engaged the left main and did a IVUS pullback to check first for the lesion in the mid-LAD, and then continue to assess any potential damage caused by the diagnostic Jurgen's left catheter in the ostium of the left main.
Yeah, and then here we have the IVUS. So we see some disease, but immediately we see again a huge hematoma, and we see actually not that much disease in the vessel itself. And you see that the hematoma is continuing and continuing.
Submedial or subintimal?
It's a submedial because again, you can appreciate the media and it's blowing up again. You see it, but it doesn't compress the lumen that severe. And here, that was an important point that we saw a loose flap with an opening in there. And let's look again. Here we have here starts the hematoma again, and we appreciate the septal and diagonal branches. We see it submedial. You see behind the black ring of the media, the vessel is blowing up. It's not that strongly compressed as we saw with the former case, but nevertheless, it's over the full length. And then look at 11 o'clock, but there is a loose flap that the intima and the media were broken. And then there is another spot more proximal that we put your attention on later on, but we will show this in detail. Here is a spot that you see that the media and the intima and the media are broken. You can see this black line going to nowhere. And that is what we anticipated, the entrance of the, yeah, exactly, the entrance of the hematoma. And again, it's a anterograde dissection, so the false lumen between the media and the adventitia is filling up, and that's why you see your hematoma all the way through.
Yeah.
Then we were,
So one more comment, Jurgen. So as you know, SCOT, there are different types of SCOT. We will not dwell into all of the details, but what I think is important to realize that you have spontaneous hematomas and spontaneous dissections. Those are not necessarily the same entities. Spontaneous hematomas might arise without having a dissection flap, either proximal or distal. So you might look until Christmas, but in some cases you simply don't see a dissection, either irrespective of whether you use IVUS or OCT. But in some cases you do see a dissection. I think this is approximately half of them. You still see a dissection, like in this case, which is then appreciated by the clear discontinuation in the intimal layer here, which is always hard to interpret on still images. But if you put the IVUS on short loops or dynamic view, you can better appreciate the small intimal tears that might be present in these cases. But then, interestingly, Jurgen, we also saw here really at the ostium of the LAD, and you really can see the IVUS catheter jumping from the ostial LAD into the aorta. You can see here ostial LAD, poof, aorta here on the left. You can see that this lumen gets enormous because of the entrance of the ostium of the left main. And here we can see this hazy, whitely appearing mass from, let's say, 2 to 4 o'clock, which looks a little bit like an erosion in an area where there's no plaque.
Yeah, exactly. And that is, I think, that is a spot where the diagnostic catheter was going in the roof, and that you could see a little bit this small mountain on there. And that is why we always say, if your catheter is not fitting in like that, please take another catheter. And that's also the case why we always check the left main with the last pullback, that we disengage the guiding catheter to see if we can see some disruptions in here.
All right. So we continued here. And then we're puzzled. Because we knew that this case was, that was damage due to the catheter. That was this small erosion-like appearance of the ostial left main. And there was a hematoma. So in a patient that would enter in your lab, for an elective case, stable angina, you would say, well, 1 + 1 is 2. Those are very unlikely to different pathologies. This has to be related. Conversely, this patient presented with a out-of-hospital cardiac arrest due to ventricular fibrillation, which quickly recovered after resuscitation and the AID shock. So there must have been something. That having said, what was also interesting is that, at least based on the IVUS findings, you do see this bright white erosion type appearance here in the ostial LAD. But then there is a distance, and if you would measure that, and we did that, you have an 8 millimeter distance up until the point where there is the dissection of the LAD. So what you would expect, at least what I would have expected, is if this dissection in the met LAD would have been iatrogenic, that should have been a continuation of the damage caused here at the ostium with the distal part. Anyhow, we will never know the definitive answer, but the point is that we were surprised by this case, and we had to deal with it at that point in time. Having a patient that at that time was hemodynamically stable, had a LAD and left main that were at all occasions, from a luminal perspective, patent. And we had 2 pathologies that were not necessarily related, but in theory, obviously could have been related. So we continued here, and actually this kept the patient in the hospital, according also to current SCOT guidelines, and the fact that here there was a patient that was at risk for future deterioration. So we kept her in the hospital, and then 2 days after discharge, so that was 7 days later, she presented again. So we kept her in the hospital 5 days, everything fine. And then 2 days later, she came back. Unstable angina, And again, an EKG is which showed you diffuse signs of ischemia. So this patient again was brought to the lab, and then you can see how horrible this left main and LAD looked at that time. So this is 1 week post-procedure, and definitely showed a lumen that was no longer nicely patent.
Yeah.
So here the operator had to deal with the patient that was at that time hemodynamically unstable and had a left main that was only very, very thin in an area which we knew already that was dissection and hematoma, so a risk of ending up in a false lumen. So in this case, the operator here re-engaged the left main and did to start a pullback of the diagonal branch, simply because of the fact that the first wire quickly went into this diagonal, which already suggested that this wire would be in the correct lumen.
Well, and you could see that the hematoma was already starting in diagonal, but here you see proximal that now the lumen is compromised by the hematoma.
Yeah.
Well, that fits actually that we have an open connection with the hematoma, that is an anterograde hematoma, that it stayed, that it was filling up like that, and that it didn't cure by itself.
Yep.
And that's the situation that the lady was now in. You will see that, you will see there we had the opening, that we saw that, and then 8 millimeters before, and that is right around here. Then
so maybe 1 second. So here we start this way, and you can see always put the catheter at an area which you see a healthy 3-layer appearance before you start your pullback. And in this case, already this first impression of the start of the pullback, in which you saw this healthy 3-layer appearance, is already a moment of relief, because at that point, you know, the wire and also this IVUS catheter is in the correct lumen. And then it's a matter of appreciating the enormous amount of hematoma with a vessel that is now approximately, I think, 7 millimeters.
But you also see sometimes in the true lumen where the catheter is in, that the catheter sometimes, the IVUS catheter sometimes blocks the vessel, so that you have also non-moving blood in there, because the narrowing is so severe that the IVUS catheter is blocking that. No problem. After the pullback, you remove the catheter immediately, and then you can appreciate at each your pictures.
But then we continued with a pullback from the LAD.
And now you see that the wire came submedial, because we had a wide opening. And now we see that we were in a false lumen. We will repeat it in here. Now we're in the true lumen, but I go through with you. Here we are in the false lumen. The true lumen can indicate the true lumen in there. So you see the media around. It's a sort of cap above the IVUS catheter, and appreciate and here we enter the true lumen through this line. And you see this has nothing to do with the spot where we had the guiding catheter or in the roof. We play it again. Look at the false lumen. Look at the blown up submedial space, and here we enter the true lumen. Now, if you see this, then you have to reposition your wire. If you, placing stents in here, that's not done, because it ends to nowhere, and it also closes all your side branches on the way, so it makes things worse.
But this is also exactly the reason why we also always start with 2 slides on the basic components of the normal healthy artery. As long as you always keep that as a basic principle in the back of your mind, you will always be able to immediately realize that the point where you start a pullback, which will appear here at frame here, poof, you immediately see this is not normal. And this is not a plaque. This, which you can see here, is this fluffy, pushed away balloon on the outside. That is the true lumen.
Flow through that, you see? There is one other trick to determine that. This is, of course, a short pullback, but if you make a longer pullback, you always see side branches emerging from the true lumen. So if you see a wall between the bifurcation, then you know you're between the bifurcation and your IVUS catheter, then you know that you're in a false lumen, and you have to rewire.
Yep. So in this case, the operator rewired and did some ballooning in order at least to restore the flow, which at that time happened. And then he did another pullback after the pre-dilatation, again, to Daemen to at least determine, what segment would need to be stented.
Yeah.
And this is always very complex in case of hematomas, because typically if you put a stent or you put a stent which is too short, you will squeeze out the hematoma like a sausage, because this hematoma will typically not be dislodged if you don't do things like cutting or scoring balloons. Jurgen, the IVUS. So we need to play this one. Yeah, apologies for the quality.
Yeah, so we have here a little bit intimal thickening, eccentric plaque. And here we see that there is a hematoma there at 1 o'clock. And if I look in there, that we are now in the true lumen, you see now a thin, and now you can appreciate that the side branch comes in the side where the IVUS catheter is there. Now we are sure, now you can be sure if you were doubting that you're in the true lumen. And we see here that the media is still loose from the wall. So we have a submedial hematoma in there. But if you would place a stent in this vessel here, then you're okay. Then again, size your stent on the spot, preferably not on the spot where the vessel is blowing up due to the hematoma, like here. That you have to make a realistic sizing. Again, here you see the side branch coming from the same side of the IVUS catheter. If you be in the false lumen, then this black line of the media would be in between you and the side branch.
Yep. Okay, so in this case, we continued with stenting this LAD. We took 2 long stents in order to be able to cover the full hematoma with the 4040 and a 3015 stent in diagonal branch, casing balloon, post dilatation, spot with a 4-5 non-compliant balloon, and a very good angiographic result. We finalized here with a IVUS pullback, and what is interesting is that this nicely demonstrates you, if we could play the IVUS here, that
we still have a little bit hematoma.
Yeah,
that's not surprisingly, but you see that the lumen is not that compromised anymore, and definitely will not fill further. That's at the end, this will emerge, this will get away.
Yeah.
So we're still distal from the stent, and actually we have a normal vessel. There's no plaque in there. Only we see the hematoma. You appreciate the difference between the flow, even in this bad quality picture, and the non-moving vessel. And here we see the stent. Yeah, we see a nice deployment. Now you see that the adventitia and the media are close to each other. And this is also important because sometimes can be very difficult that you have the impression that you have a malopposed stent while it is opposed against this thin media. Don't step into the trap to think, well, we have to post dilate till the wall. So remember, the size of your hematoma is not the correct size. Here you can see it, that's behind the stent. There is this black line, so that means your stent is opposed. Although you may think that at 7 o'clock that you see malposition. That is in this case not true. That's why it's so important that you know what you're dealing with beforehand.
Yeah, yeah. This was the EKG at discharge. The patient nicely recovered, and as of today is doing well. Any questions, comments? Because we wanted to conclude the hematoma part at this stage.
Yeah.
So I think one of the key take-home messages is learn to appreciate the healthy lumen, learn to appreciate how a hematoma looks like, because irrespective of all the cases we showed you, the appearance of the hematoma is rather typically, it's a very well subscribed cap on the vessel wall, so to say, which is typically nicely and solidly delineated, so it typically doesn't have a very irregular aspect. And it might make sense to look for dissections which could, as Jurgen nicely mentioned, fill the hematoma. In cases which are spontaneous or real spontaneous hematomata, the likelihood that they will progress and at the end will end in a full luminal compromise is lower as compared to hematomas that are subject to large inflow dissections, which might continuously flow the hematoma and thereby blow up the vessel even more, and might have a higher likelihood as to deteriorate, as shown you in this case.
As a matter of fact, we saw those dissections that you described, and then we checked after 3 or 4 weeks with an angiogram, and then we saw that it was completely recovered and the patient was happy. Actually, I remember a case that a patient was here with a SCOT, and of course this patient was completely upset because came out of the blue. And then she heard from the physician, well, we'll do nothing. And then, but what we do, because this will recover and we will check this after 14 days. But then the patient refused to leave the hospital until she saw the movie. So we sent her back to the referring hospital. You remember that? That's but then it was gorgeous, and this patient was very very happy and relieved. I remember, because this comes out of the blue for patients, because they have often no cardiovascular history, even no known risk factors.
Absolutely. Yeah. All right. So far the hematomas then. Aneurysms. Obviously, you all know aneurysms, you all see aneurysms, and you all struggle with treating them, or perhaps struggle with leaving them alone. Simply because the tools and technologies we do have in the cath lab simply don't match the needs to optimally treat aneurysms. In patients that actually come in with problems related to the aneurysms, because obviously aneurysms per se do not warrant treatment. But this was a patient that had a aneurysm and was in need of treatment. Because this was a 52-year-old female patient, active smoker, no known cardiovascular history, and he showed up with the inferior STEMI. You can clearly see this EKG, sinus rhythm, ST segment elevations in the inferior leads. No clear depressions in the anterior leads, but clear ST segment elevation. And this patient was brought to our cath lab actually very recently, in which we started with a right radial approach. This was a Jurgen SLAV 3.5 in the left system, showing you a actually normal, I would say, left coronary system. Right dominant system, but this left system, mild luminal irregularities, but no apparent or relevant disease. So different it was on the right side. This was his right coronary artery, showing you two things: one, a enormous aneurysm, and a something that looked like a thrombus. So then, obviously, the key question is how to proceed here. First, is there a need to do something because there's TME3 flow? Second, is there a possibility of crossing that lesion and stenosis? Third, is there a need to put a stent, and is there even a possibility to put a stent? And finally, what do you do with your antithrombotic or antiplatelet therapy in the follow-up of this patient? All questions that, at least in our practice and in my belief, are very, very hard to answer without having more detailed information on the exact intravascular pathology, which could only be derived from either IVUS or OCT. But in this case, I think preferentially by using IVUS, given the subtotal occlusion of this lesion, which probably would not be able to visualize with contrast and OCT.
Yeah, maybe it's good that we ask some of the audience to put some comments that if they see this and even without the IVUS, think they don't have an IVUS, I cannot imagine, but they don't. What would they do in this case?
So who would put a stent in this patient? Just type yes or no in the chat box, and we will pull a little bit the answers.
Yes, I see. Yes.
So we have one yes.
Yes.
That's good.
Yeah.
Maybe somebody who would refer the patient to the surgeons. So since we have a little bit of problems by getting the feedback, we will just continue. So what we did in this case, we crossed this vessel, which was already hurdle number one, because these lesions can be very, very difficult to wire, because of the fact that your wire might get trapped in this balloon of the aneurysm that might not find its way through the to the distal part of the vessel. But in this case, with a simple BMW, we were actually relatively happy that this wire actually crossed very easily. And then we didn't do anything. We just started with a IVUS pullback in order to get a better impression of the intravascular pathology. And then Jurgen will take you to the IVUS assessment. In this case, we will not show you animated GIFs, but we will show you the live ACIST Kodama console we have here at our disposal to show you the case.
So we started quite distal in the right coronary artery, and what we appreciate is that we do not have a disease. I call this a normal vessel.
Absolutely.
So we see a side branch at 6 o'clock coming, and so it's quite normal for a long segment. Here we have some intimal. Here you can appreciate some fibrous intimal thickening. A side branch on top. Again, some intimal thickening, but you see that the lumen is still, it's a very big lumen there with a good flow. Then we get some more plaque, more fibrous, fibrofatty plaque, a little bit, I would call this mixed fibrous and fibrofatty, or intimal thickening, definitely, and I'm going to measure that for you later on, less than 50% plaque burden. And then we start in not a side branch, but here we have this cul-de-sac of the aneurysm. And now you also see that despite that we have broadband 60 megahertz, that you could penetrate a lot of the vessels, that still that here this vessel, this aneurysm, is actually too much for the 60 megahertz, because you can't see the whole thing in there. But what we appreciate here, and then I stop in here, and then I will let it run. This mass in here, where the IVUS catheter is against, and if I make this in movement, then you see that there is a double layer at the plaque, and this is what I call subacute thrombus in there. So there is thrombus in here, and definitely you can appreciate that if you compare it with the moving blood in here, you can appreciate thrombus also on this spot in there, and definitely there will be also thrombus more deeply in this bag, what we appreciate on the angiogram. So where's this thrombus coming from? So then we go more proximal, and then we will see the minimal luminal area, this stenosis. And then if we move a bit up to this stenosis, then, and I go up and down, then we appreciate here, and I'm going to show you this part here. There are some fibrous components that we have here, a massive plaque burden, a plaque rupture in there, in a huge fibrofatty, or actually even mixed plaque with some calcified components in there also. So we're talking about here a huge plaque rupture. You can see the cavity in here. This used to be, before the plaque rupture, that you would see a massive plaque, but here the fibrous cap was broken, and then because of the plaque rupture, then probably there was necrotic material, inflammatory material, and that is very thrombogenic, so that immediately we get thrombus, good thrombus, and also because of these, probably there was a huge how do you call it, remodeling also around here, and that created the huge hematoma, or the huge aneurysm there. Now then, what we appreciate here, and I just could show it in here, that we have here the minimal luminal area in there. Just for the record, normally we're not going to measure minimal luminal areas in here, because we're dealing what to do, and then we start deciding what do we have to prepare. Can we measure for a stent immediately? But just for you, I will measure this minimal luminal area, 2.6 square millimeters. Well, that's definitely too less for this size of vessel. Yeah. So
this is important. So this again confirms that there is a need for further treatment. This MLA of 2.5 or 2.6 here in a reference area. Maybe that is important, Jurgen, because you know that the cutoff for treating stable lesions is around 2.5 to 4 square millimeters if you would rely on IVUS. But what is a important cutoff that you could use is a percentage area stenosis of 75% or more. And if you would go to either proximal distal, Jurgen, to a healthy reference area.
Well, that's not difficult to find here.
Yeah.
So, well, in here I can call this healthy because it's less than 40. So I will make an area. By the way, I'm using a mouse because that is in this situation easier, but in the cath lab, you can just use your finger because the screen is bigger and it's more sensitive in there. That's going really nice. So I would try it. So we have 8.9 square millimeters in the meantime. Now, then if you say what would we have, 2.5, that's more than 75%.
Yeah, that's around 70%. Yeah. And that's even distal. If you will go proximal, you would even find a larger.
Then, well, let's do that.
A larger area.
Doesn't I go too fast? Sorry.
So obviously, in this case, this is not so relevant. But just to demonstrate you that if you have IVUS in a patient with this stenosis, IVUS can really help you to get a better impression of the severity of the significance of the lesion. I always, at least what I learned from the experience here with imaging and physiology, is that either if the luminal area in a large coronary is below 2.5, the likelihood that that will be functionally significant by FFR, IFR, NHPR, VFFR is virtually 100%. Conversely, if the percent area stenosis is above 75%, like in this case is the case, here you have a proximal area of 11.7, so that is more than 75% stenosis. If you have an area of 2.6 in this case, that also attests to a vessel that probably will have a FFR that is functionally significant. Anyway, besides this small sidestep, we found a aneurysm with a diameter that we could not even measure. But we also saw a plaque rupture just at the neck of the aneurysm.
Let's go back, then I can show you. Then I can put it in your. I have to go back a little bit. I went too far. Yeah, here it is. Here it is. Here is your plaque rupture.
And if you would say, well, this subacute thrombus, yes, I do believe that, but I find it very difficult to appreciate. I would say, yes, you're right. This is indeed difficult, but you could very easily train yourself, because if you have a patient with a STEMI and you pull out the IVUS catheter, and maybe you can, Jurgen, you can go to the part with the subacute thrombus.
Yeah.
If you have a patient with a thrombus and a STEMI and a very high likelihood of a rupture plaque, just pull out the IVUS catheter, use it to guide your procedure, and by doing so you will learn to appreciate how thrombus looks like. Here you very nicely see the delineated black cloud on the left
here.
side, which
Here.
is more like organized thrombus, but on the right side, where there is, you have this sponge-like meshy appearance of something that you cannot really identify. This is not fibrotic, it's not white, it's not calcified, it's also not white with a shadow, but it's blackish with some spongy like appearance. This is very typical for organized for a subacute thrombus reflecting a freshly ruptured plaque with probably lipids and thrombus that are connected and generate this subacute thrombus like appearance.
Well, we have an article on the way, that about explains you perfectly why you see the thrombus as you see it, and some helpful tips and tricks how to recognize that, what to do. Actually, we also earlier we wrote a book chapter, but books, nobody reads books anymore. So we decided to make an extract from that book chapter just for IVUS. And I can tell you, if you take a bit of time and you review your stuff, you will not recognize it immediately with your first patient in the cath lab. But if you review that and think about a patient like that, you will start seeing more and more. And then you will also agree with us that in the consensus papers that what still now says that with IVUS it's not possible really to appreciate thrombus, that it's a little bit more sophisticated like that. And
all right, good. Let's go back to the case.
Yeah. Well, what you want to place a stent, but where would you?
Yeah, so also this case was included in the Spectrum study, which is a prospective observational studies we're running now in the Thorax Center with the support of ACIST and MicroPort to look at the impact and consequences of contemporary stenting using HD IVUS in a consecutive cohort of 200 STEMI patients. We're well on the way with this trial, and this case was also enrolled. And one of the secondary objectives of this trial is also to adjudicate the effect of thrombectomy. So manual aspiration thrombectomy in a mixed bag of cases with very fresh, acute, subacute, or maybe organized thrombus, and to see whether IVUS can predict the effect of thrombectomy, and whether or not IVUS or thrombectomy that might have particular effects in specific times of plaque ruptures and thrombus. That said, in this case, because of the clear amount of thrombus, both subacute and organized, we thought, well, let's do a thrombectomy, also because of the fact that stenting here was not really appealing. So we continue with thrombectomy just to see what that would result into, and then we repeated the IVUS pullback, and Jurgen will show that to you in the next pullback.
Yes, well, you could appreciate that we started a little bit more proximal with the IVUS. So we have here this this fibrous plaque, what we saw before. Then if we continue, then we see again this huge hematoma. But in this hematoma, you see that there is now
better flow.
Better flow. We don't see this mass against the IVUS, that the IVUS catheter is resting in there. And what we also can appreciate, that we see, well, there's a little bit thrombus left in here, just for the record, or just that you start to recognize that. But we see also more thrombus removal proximal, and that makes it easier to appreciate that we really have a massive plaque rupture that actually already started here in this spot and then continues to the spot that we initially saw. So it's not only this spot here, but it's a massive plaque rupture that extended, and I put the point there on the longitudinal view from here to here. You can appreciate that we had a huge positive remodeling, a huge plaque in there, and that ruptured. Now that means that the thrombectomy did its job. It made the things clear. That's why it's so important to do an IVUS afterwards to check the work. And then I think, Joost, this was the moment that we can measure for stent sizing.
Yeah,
but
so we had to decide what to do,
Yeah,
how to proceed.
exactly.
Do we just do another balloon
Yeah.
and then leave it like that? Or do we want to try to
Yeah.
put a stent? And what is
Yeah.
interesting here in this case is that if you go distal in the aneurysm, you see that here, yeah, the vessel is patent. There is not much to do for stents. And distally, distal to the aneurysm,
that's also patent.
that's actually very
Yeah.
healthy.
See?
So also here, there's no need for stenting.
Yeah.
So we thought, so we now have confirmed that this plaque rupture is just at the neck of the aneurysm. So what if we would tailor a short stent,
Yeah.
starting at the inflow of the aneurysm in order not to generate. So here,
I think, well,
yeah, let's do that
this part
here.
but you don't want to cover this small
Yeah,
piece of
yeah,
thrombus?
Yeah,
Shall
okay.
shall we put it in here?
Yeah, maybe a bit.
I think then you put now. Okay,
So I
let's
wanted to have as little because obviously a regular
yeah,
stent would
then I
have,
go back a little bit.
would generate a lot of
Then let's stay
a lot
here.
of malposition.
Here I can see the wall.
Yeah.
Yeah. Now I make a bookmark here, and then
We find a healthy reference
Yeah.
spot proximally.
so we go over this the plaque rupture,
Yeah.
and then I think this
Yeah.
this looks good, eh?
This is excellent.
Okay.
Yeah.
Now what I do now, I will measure now the size, and then automatically the machine gives us. You see, I do it in a bit different way. Now I make clicks. First, I did it with by hand. It's depending on how you like it. So 13.1 square millimeters, but automatically and for free, thanks to ACIST people, we get the maximum and minimum diameter in this cross section. So we had 4.3 millimeter in there by 3.8. Then the length, then I'm going to, and you see here in millimeters. In this way, you can make with a caliper a length. Then we take from one bookmark to the other, and we get here a length of 7.3.
Yep.
And
Yep.
probably you're going to round it up a little bit above.
Yeah.
Yeah.
So if we go back to the case, we indeed continued here with picking a very short stent. We took a 408. That was the largest size we have had available in terms of diameter, and the length of 8 would have been sufficient. There was no calcium, so not really need to pre-dilate in this case, because additional maneuvering and balloon dilatation would only have increased the risk of dislodging the thrombus, creating no reflow, and creating dissections in this ruptured plaque area. So we went for direct stenting after the thrombectomy, 408 Firehawk stent. We post-dilated that just in the neck of the aneurysm with a 5.0 non-compliant balloon. Typically in these cases, I don't make angios in between all the individual maneuvering because of the fact that IVUS will simply show you the result. So the good thing also about using IVUS in STEMI cases, and I think using IVUS in general, is that you really can reduce your contrast volumes.
Just a moment. I want to see your
And as long as the patient is stable, there are no new EKG elevations, ST segment elevations, or arrhythmias, the likelihood that you have severe acute problems that cannot wait for another 30 seconds to do your IVUS run is highly unlikely.
Now let's see what you did.
Yeah.
Yeah. So you place.
We go back to the IVUS.
You did
Yep.
post procedure. Well, we start. You see, we're getting more and more shorter. You go more proximal, and let's run this. There we go. And then you see that we are here in the aneurysm. The aneurysm is free of the stent, just like what is the intention. What you see, oh, this is nice, and that is, you see often with this higher frequency catheters, that you see there's no plaque in there, but you see turbulent flow, that you see an area with faster flow in the same lumen than slower flow. There's a bit turbulent flow, and that the slower flow you can appreciate, but that the blood speckles are brighter. Yeah. Then we go proximal, and there we have, well, I don't know how you did it, Joost, but it's exactly on the edge of this it doesn't even protrude into the aneurysm. So you covered the vessel in there. So we appreciate here the stent. It's not protruding in the aneurysm, and we have a nice apposition there. And then we also check for edge dissections, what we do not see. I always say no visible edge dissection. They need to be big enough to appreciate. And then, yeah, I think that if we look now at the minimal luminal area in this stent, that now I will go with the free hand again.
So this is also not directly related or particular for this
Yeah.
case, but if you do your post-PCI assessment, always adjudicate 3 basic things. 1, check your minimal stent area, should at least be 5. That is a very simple to remember basic concept, at least 5. Then you check your edges, 1 for dissections, 2nd for plaque burden.
Wow.
So there should be no visible edge dissections longer than 3 millimeters. Plus, there should be, in theory, or not in theory, preferentially, not a plaque burden larger than 50%.
Sometimes you can, because if the vessel is that disease, sometimes you cannot achieve it. And of course, then you need to go for the acceptable lumen, and you know your patient. Well, by the way, this is how you do a plaque burden. You draw the lumen area and you draw the total vessel area, and then well, there's discussions, EEM, forget that, just draw on the media, because that's easy to appreciate, and then automatically you get a plaque burden, in this case 40%. And what we know from the papers from Glakov and Hermiller, that until 40%, or 40 or 50%, the vessel, the lumen will not be compromised. Then you only have positive remodeling. So you can appreciate, you can be sure that this here, the lumen, was the original size of the vessel itself. And in this case, 40%. And if I go back to the thing, then we have here, well, you said 5 square millimeter, well, 8.6 square millimeter. I think that looks
largely sufficient.
It's very likely sufficient.
Okay. Interestingly, so next slide, we can show you the this is the final pullback, and then you see the final result. So what you see is a vessel with a nice TME grade 3 flow, a aneurysm that is obviously still there, but a vessel that is relieved from its thrombus and subtotal ruptured plaque, a stent that is not free floating in the aneurysm in order to catch thrombus for the rest of the life of the patient. So we were actually quite happy with this result. Nevertheless, we discharged the patient on clopidogrel and a NOAC because of the fact that these aneurysms are a true cause of thrombus per se. So that's just to illustrate you how IVUS could help you to really make a difference in the treatment of these aneurysmatic vessels in patients that you do want to treat percutaneously, and you don't want to torture with covered stents or coils or other exotic types of treatment. Questions, comments? Because besides the fact that I'm a little bit hungry, we ran out of cases for today, but obviously we remain at your disposal for any particular questions you might have in terms of hematomas, SCAT, dissections, sizing, measuring. We will be back, I think, next year with new editions of the ACIST IVUS course, in which we will bring to you new cases, new pathologies, and new examples to demonstrate you how IVUS could make your life in the cath lab easier and sometimes even faster.
Can we do requests that people can go to ACIST and ask them, well, we want to see this, or can you show that again?
Absolutely.
And like that,
people
So
are
do-
able to contact the local representatives from
Yeah.
ACIST, as well as contact us directly, j.daemen@erasmusmc.nl.
Yeah.
In case you have particular requests for specific cases
Yeah.
you want to share, or you want us to elaborate on.
Yeah.
I think that is a nice step up to the final slide actually we prepared for you today, inviting you to also submit your own cases. So with that, Jurgen, many thanks for the great input and very worthwhile insights in all the cases we've discussed today. We would like to thank you for watching. Thank ACIST for making this happen again. And we look forward to seeing you soon in future editions of the ACIST IVUS course. Thank you.
Okay. Hey, take care. Bye-bye.
Jürgen. Looking forward to the next webinars next year, and see you soon with a new edition of IVUS.
Excellent.
Okay, excellent. Bye-bye.
Bye-bye.